Welcome to the Critical Care Medical Control Protocol update video. My name is Mark McKenzie. I'm the Provincial Medical Director for Air Ambulance, and for those who don't know me, I've been involved in STARS and air ambulance or transport education in one way or another, be it through medical direction, simulation, academy, or STARS ASI, or transport physician for quite some time. This is the second version of the CCMCPs. The revision process took well over a year and included sweat equity from Manitoba, Saskatchewan, and Alberta. Doctors Doug Martin, John Froh, Darren Hudson, Eddie Chang, and myself made up the physician core of the revisions group, so these guys deserve special mention, as does the CCMCP working group, consisting of STARS and AHS talent who held our feet to the fire and got this thing done. But the contributions to the content of the CCMCPs don't stop at these two groups, and the umbrella of recognition is large, encompassing other physicians and practitioners who assisted with literature reviews, who are involved in the STARS airway course and ventilation manual, local pediatric and obstetrical experts, PADIS, ILCOR, and others. Finally, a shout out to all those critical care practitioners, mostly from the HEMS and fixed wing world, that kept us honest by giving the protocols a sober second look and providing valuable feedback, often when we thought we were already done. The first version of the CCMCPs was a massive attempt to take the content of the STARS guidelines and format them into an accessible vehicle with links to evidence for broader approval and consumption. I think most of the changes you'll see in version 2 can fit into two categories. One being an attempt to clean them up, make them more navigable, and the other to ensure that the protocols align with current practice, to remove prescriptive references that weren't supported by evidence or practicality, and better reflect their critical thinking and experience that we value of our practitioners. In improving navigability and access to the information, we've removed a number of procedures and integrated them into their associated protocol notes. Transcutaneous pacing, umbilical vein catheterization, Linton tube insertion, escharotomy, control of life-threatening hemorrhage. These procedures are now integrated into their obvious associated protocols. Tall man lettering was standardized, medication doses were standardized into weight-based format when it made sense to do so. As far as aligning with current practice and reflecting critical thinking, we removed many prescriptive definitions to hypotension, such as systolic under 90 or 100, or ambiguous terms such as unstable or shocky, provided guidance for the practitioner on what might make them consider a patient hypotensive, and used the term simply hypotensive or at risk of hypotension, with the practitioner able to recognize these patients and adjust their strategy when delivering analgesia, sedatives, or preparing for intubation. Likewise, there's guidance around perfusion goals for various clinical situations. The identification of adequate perfusion, be it whatever combination of MAP, pulse quality, urine output, mentation, etc., will be up to the practitioner. The exception, however, is when the current evidence or expert opinion might identify a specific perfusion endpoint, such as a higher MAP of 85 in the head-injured patient. Unless there's evidence for normal saline or ringers in a particular clinical scenario, the protocols will simply reference crystalloid. And likewise, there is evidence in a if there's evidence in a clinical scenario for a specific vasopressor such as epinephrine or norepinephrine, the AMC will be directed to simply start an available vasopressor. There are many examples of new evidence influencing this version of the CCMCPs. You will note, for example, that the protocols encourage conservative fluid resuscitation to meet perfusion goals in hemorrhagic shock. There is new information in a pneumothorax protocol regarding recognition and treatment. A C-spine assessment protocol, which is based on the well-evidenced pre-hospital use of the Canadian C-spine rule, pertinent point-of-care values in managing hemorrhagic shock, and many others. The backbone of the CCMCPs is and will continue to be clinical expertise, and it's often the practitioner which influences CCMCP revisions. The CCMCPs should be the critical care practitioner's main clinical resource on missions, reflecting care that is evidence-based and practical. They should also be accessible, legible, and navigable enough to be a resource for any practitioner, anywhere, providing care to a patient with critical injury or illness. I can tell you that the CCMCPs are referenced or used by a number of other EMS organizations in Canada. including those familiar to us that provide critical care transport. We've received inquiries from organizations both inside and outside of the country interested in using the CCMCPs as a foundation for their own protocols. So I really hope all STARS practitioners, those AHS fixed-wing providers, and any other critical care providers involved in the shaping of this version of the CCMCP share some pride in them. Thank you for contributing to them, for reviewing them, and mostly for providing the world-class level of critical care transport that inspires them.